Thank you very much for this very kind introduction. Thank you all for being here. It's a great pleasure for me. Let's see that this gets to working. Okay, here we go. Soft tissue augmentation. You can see in this image, is quite essential for a good final outcome. We had a lecture on bone regeneration, the basis for osseointegration, longevity of our implants, but just as important is the soft tissue regeneration. And today's problems, let's see if this is here are some clinical cases where you see the soft tissue is the main issue that we have to solve. Very difficult to address, very difficult to solve. Do you have one that would work? Let me see if I can change this. The remote. Let me go on like this in the meantime until we try to solve this problem. So there's widespread need for soft tissue regeneration. I'm very happy to be invited here to this 26th annual Congress. Okay, thank you. Of the Indian Society's Oral Implantology. Let me go back. I know it's the 30th anniversary, so it's a special honor that I've been invited to be here. Thank you very much. We look back to 4 weeks in India now. I spent 4 weeks working at Rangoonwala College of Dental Science and Research Center in Pune. So it was great to have this experience living and working in India. Just when I arrived, the first day I was there, they already put me to work and I had to operate on one of the patients they had scheduled. But I was also lucky enough to be there during their convocation ceremony and I was the chief guest. So this was very memorable when all the students received their diplomas, to see the joy in their eyes. People who had been working hard to become dentists and now dental professionals. Just as impressive was the day 15th of August, when you have your Independence Day, and this was at the place we were staying at the residence, and they were unfolding the flag and singing the national anthem. Our Independence Day is August 1st, so we've been independent for 14 days longer than you have. And Dahi Handi Festival was amazing to see the crowd of people and the daring towers that these young kids were making to smash the clay pot and get to the dahi inside. We also took some trips to the vicinity. This is Singhahat Fort, many fortresses around Pune, very important historically. We had an excellent guide who explained to us everything which was interesting there. And then we had the chance to travel to Goa to see the countryside, the next state south to Maharashtra. And we also learned what it means to be in India during monsoon. Actually, Pune was closed down for 2 days. The authorities said college was closed, everything was closed. They also had to let water down from the dams. So the water levels were very high and there was some threat for the local people. Okay, now I bring you the greetings from Zurich, from the University of Zurich, where, as you have heard, we're a department of prosthodontics, of reconstructive dentistry, material science, implantology, and we have a very strong focus, of course, on reconstructions, also using implants. But today, we'll talk about soft tissue corrections. There are different aspects. We can have recessions, where we correct soft tissues. ridge augmentations, maybe also ridge preservation, where we do this for maintenance of soft tissue volume, or enlargement of keratinized tissue. Not so much at teeth, maybe occasionally, but a lot at dental implants. So if we look at the time points when this can be done, I have listed the time points which we use clinically here. So prior to implant placement, during the phase of osseointegration, during abutment connection, in combination with augmentation procedures for bone, simultaneous with implant placement, during the phase of temporization, or prior to the delivery of the final reconstruction. So we have a lot of options, so we have a lot of decisions to take. And you can imagine that the amount of time available today will not suffice to cover all this. So I will focus primarily on the ridge augmentation for aesthetic purposes in our patients, looking at materials that help us improve the care for our patients. So what is the current procedure of choice? It's the autogenous soft connective tissue graft, usually taken from the palate, as you can see here. Can be used here at an implant site. Patient referred to us, malplacement of an implant, is unhappy with the looks. Implant is too far facial, so we remove the reconstruction. We grind the abutment, maybe a little bit also the implant neck itself, make it temporary, and then we do an enlargement for the thickness. Not so much for vertical gain, this is very difficult at a place like this, but to increase the volume to prevent further recession. So here's the final situation, and you can see what it was like before. So we could augment a little bit. There was some recession even at the end, but we could improve the situation a little bit, but it's more symmetric now and the patient is happy. So we can fix problems that we encounter with soft tissue graftings. But there are also problems with the soft tissue graftings. When you go to the internet and you say, stories from I had a gum graft, the top one says, the procedure from hell. And it's probably not the treatment, but it's the harvesting. So there are limitations. We have anatomical limitations. We've heard from the previous speakers, if we have xenografts or allografts, they're usually there in large quantities. So the autograft is always limited in quantity. We have complications, primarily at the donor side, but also at the recipient side. This can happen, patient from our own department. And we have swelling, bleeding, which are very frequent, and the pain associated with the donor side is the most critical. Now, the idea is to replace these grafts. So use an artificial material. And many materials have been tested. We have tested a lot of materials in our department, and we think that the collagen is one of the materials which helps us solve some of the problems. So the wishes for the future are replace the grafts, something which is unavailable unlimited in availability, good soft tissue integration, of course, increase the quantity, but also the quality. So we want volume, and sometimes we want keratinized tissue when we don't have only lining mucosa. And it should be technically and clinically easy to handle. So if you look at these collagen matrices, also from an experimental point of view, this is a study we did together with Mark Hürzeler from Munich. It's an experimental study in animals, so enlargement of the keratinized mucosa, and this was tested against the gold standard, which is the autogenous connective tissue graft or the apical repositioning. So we had two matrices and the control. You can see that in all situations we could increase the width of the keratinized mucosa. So we concluded that the collagen matrices macroscopically and microscopically integrated. All three groups, there was an increase in the width, and the collagen had a minimal increase in thickness without statistical significance over the controls between the two. So they showed a favorable clinical handling. So this is a good starting point. This is a clinical example. Planning to place an implant, you see the lining mucosa is almost at the crest. So maybe here it's an indication to do this, usually when we can prior to implant placement. It's a tricky procedure. We need to manipulate, split thickness flap, suturing is difficult, and then maybe we can leave it for open healing, or here we use the template. We transfer the template to such a collagen matrix, and then instead of taking an autogenous graft, we put the collagen matrix there. This is during healing. This is a later time point, and this is after completed healing. You can also see the situation before and after. It's always a little bit disappointing how much we want to gain and how much we finally gain. We really only gain a large amount when we do use an autogenous graft, but of course with lots of problems. But we do gain enough so we can make a reconstruction where the borderline everywhere is in the attached mucosa. This is the aim of therapy. There's been a study from Spain, from the other university, as you just heard, Barcelona. This is the one from Madrid. It's also accepted or accredited by the EFP. 20 patients. They had the test, the collagen matrix, and an autogenous soft connective tissue graft, and they compared the two in a randomized manner. This is a situation where after reconstructive therapy, this is conducted. This is even more difficult from a clinical handling point of view. But you see here, they integrated the matrix during healing, when healing is completed, before and after. And they found that the free gingival graft and the collagen matrix again showed the same result. Good increase and then a small decrease over time until it was completely healed. So Sanz and co-workers concluded no difference between the two groups, and the collagen matrix had lower patient morbidity naturally. So when we get the same results, I'm sure when we ask our patients, they would like something that decreases their morbidity. So the new collagen matrix was effective and lower patient morbidity as stated. So the wishes for the future, if we go through the list once again, what does this matrix do for us? Most of these points are fulfilled, but not all of them, namely the volume, the quantity. It's just an area, and it still is very thin. So the autogenous graft is still needed. Now we went in a collaboration with the University of Zurich for Applied Sciences, our department, which had a different name then, and Geistig Pharma, and this would be the disclosure. This work was financed by the federal government in conjunction with this company. And we wanted to create a 3D matrix. And we went from in vitro to preclinical testing to clinical testing. And today we have something that we can use to help our patients decrease the morbidity and still get very good results. Let's look at the in vitro first. There were some in vitro studies with different matrices. There were about 15 matrices generated, which were then tested in an incubator. I have a short video for you here, how this works. This was done by the University of Applied Sciences. Yes, here we go. So this is one of the matrix schematically. Then a suspension of cells is put into the matrix. So it's soaked with, and then it's placed into the incubator. And the idea was the cells will have to grow even under mechanical pressure. So this is in a sterile environment. It's mechanically highly demanding. So first, there is perfusion with nutrition, like there is in the oral cavity, in the healing process. And then in addition, there was a membrane that exerted forces onto the matrix. And there, as you can see, this table starts to move, and this should simulate the situation we have in the oral cavity during healing. Okay, so Stefanie Mattes, who was the first author on this paper, concluded excellent biological and mechanical properties were found depending on the amount of chemical cross-linking and the degree of porosity. So different factors had to be manipulated. And unfortunately, some of these are contradictory. The more stable a matrix, the less biocompatible, and vice versa. So we needed to optimize this. So further, two matrices were selected for further testing. Now this is preclinical testing. Daniel Thoma, together with our group, did this testing in the rabbit skull and looked at it with different methodologies. You see here in color the dermis, the collagen matrix, and the bone skull, and looked at what it does in a more clinically related environment. So the loose network was more favorable for vessel and matrix stability. So finally, this was the matrix which was chosen for further clinical experiments. And the next experiment was in an environment which is more similar to what we do in our patients. So it's close to teeth, and this was an animal experiment. You see that teeth were extracted, impressions were taken, augmentation was performed, and then histological and volume analysis were done over time. Let's look at the starting here. We had little pins to identify the areas of interest. Treatment modalities, this collagen matrix, subepithelial connective tissue graft, abbreviated SCTG, and a negative control where we just opened the flap and closed it again. Here you see the autogenous, the matrix, and the sham operated site. So what did we find? Impressions were taken, and these impressions were superimposed, so you can see here, and then looked at on a computer screen, and the volumes were identified. So 1 plus 2, and then the differences were calculated. And this was done at 4 weeks and at 12 weeks. You see the sham operated didn't show any changes except a certain loss. And the two, here, the matrix and the soft connective tissue graft, they both showed an increase. And it remained stable up to 12 weeks. If we just take a close look at some of the histologies very briefly, this was again published by Daniel Thoma. We see the autogenous soft connective tissue graft, the control, and the matrix. Very nice volume gain here as well, very nice volume gain. Let's have a look at 1.5 millimeters from the crest, 3.5 and 5.5 millimeters from the crest. And we can look at the new bone in green and the soft connective tissue in red. We see that the matrix usually has even induced a little bit of bone formation. We know this from guided bone regeneration, that collagen is a very good material. And we see that we have very good new connective tissue formation in both active groups compared to the negative control group. So, conclusions. The collagen matrix was not inferior to the gold standard. So we should be able to use the collagen as compared to the soft connective tissue graft. Now, when you see these data, are they convincing for you to use this procedure on your patients Monday morning? Maybe not. So from the preclinical studies, of course, we have to go to the clinical studies. We've looked at biocompatibility and mechanical properties. We have done some preclinical animal testing, and now it's time to do the first study on patients. So what we did is, this matrix was used in patients for volume gain after implant placement when implants were still submerged. This is our normal timing. We place the implants, maybe we do a hard tissue augmentation, and then we do a soft tissue augmentation during the phase of osseointegration, and then it's healed when we do the abutment connection. So randomly, one of the two procedures was chosen. Let's look at the gold standard. We've seen this before, so I can skip it with one image. And let's look at the collagen sponge. Here, the flap is raised, and the sponge is trimmed. There was a membrane that had to be removed, of course. Here you see the sponge in situ, and we go for primary closure. It's exactly the same procedure as we do when we do the soft connective tissue graft. And here, the final reconstruction in this patient. So the test. Now, how did we analyze whether we were successful or not? We had two methods. One was using surface scans of models we had fabricated, and another one was using endodontic files. The patients preferred the scans. Let's look at these measurements first. we have the collagen matrix, the autogenous graft, and statistical significance. And we looked at the apical portion, we looked at the buccal portion here, and we looked at the occlusal here. This is where this pin or endodontic file is at the present time. And you see that there is some difference in numbers, rather large standard deviations, but we don't see any significant difference. And there is a gain of 1 millimeter to 1.5 millimeters using this therapy. So from these measurements, we can conclude that there's encouraging results in comparison to the standard of care. So similar to the autogenous soft tissue graft with no adverse reactions during the time of healing, and improvements in the patient well-being because we could avoid the harvesting of the autogenous graft. So we wanted to see how is this longer term. So we have the baseline, the 6 months and the 1 year, and we do these scans. And as I showed you yesterday, this is an excellent tool to look at small differences non-invasively and being able to store data. It's also highly reproducible. And here again, you see that from baseline to 6 months and baseline to 1 year, this was after placing of the reconstruction. So 6 months after placing the reconstruction, we have stable conditions. Pink is Getty score, width of keratinized tissue, same, no difference between the two groups. So, Dr. Huber concluded, the augmented soft tissue volume at implant sites was stable over the observation period of 1 year. Why do we choose 1 year? When we look at the literature, it's between the first 6 months up to 1 year when we find the changes, and thereafter, things are stable. The soft tissue volume and quantity did not show significant differences between the autograft and the matrix. Now, we're doing a multi-center study. This was a single-center study, and you see there's different centers we're working with in Europe to get more data and to be able to make better recommendations. So the treatment is basically still the same with one important change. And this is that we do a palatal island flap. This was described by Tinti many years ago. It's a palatal island flap, which helps for primary wound closure and helps that we don't have to displace the mucogingival line as much at the facial aspect as we do when we don't do this palatal island flap. Again, you see here, time of abutment connection. I'm just showing you a test situation, and here, provisional reconstruction, final reconstruction. Now, the next question will be now, what is 1 year? Our patients are interested in 5 years and 10 years. This is also what we should be looking at. So, key is survival and marginal bone levels when we look at implants. This is vastly documented, and we have seen from our previous speaker that also implants in augmented bone, they have a very good predictability long-term for survival. But what about the facial mucosa? If we only have good bone integration, survival of the implant, but the aesthetics are not pleasing to our patients will not be happy. So let's have a look at the facial mucosa as a focus. And this is work done by Stefan Biens. Implant sites with and without concomitant GBR and without previous or with soft tissue augmentation. So there were 18 partially dental patients, implants placed in the aesthetic zone, simultaneous bone regeneration, as we normally do in our procedures. 3 to 4 months later, there was a decision taken together with the patient whether it was not necessary to augment the soft tissues. See, 3 to 4 months, usually not enough to allow for complete bone healing. Now we're talking about timing, but enough that we can do a split thickness flap without going down to the level of the membrane. So we don't interfere with bone maturation and bone healing when we go in 3 to 4 months later. But it's still early enough before abutment connection so the tissue will have healed. So now we have this group where yes, a bone graft was done, or no soft tissue graft, was done, or no graft was done and abutment connection was performed. And now we can compare the two regarding volume stability. So impressions were taken at baseline, crown insertion, and then a 5-year follow-up, which is a pretty decent time point. And again, the impressions, they were scanned using our traditional software, and they were superimposed, these STL files. See the differences here in color. And now we can measure, after matching in our area of interest, what is the change there. And you see the data that Stefan collected, mean buccal thickness in the test and in the control over 5 years, there's about 0.5 millimeter of loss. Probably clinically not relevant. The buccal mucosal margin, the height, also we have about less than 0.5 millimeter. So probably lower than the visibility. And we also measured the ridge width, which is in the same magnitude. And interestingly, we don't see differences between the two groups. So we can look at the margin height and we can look at the thickness. Okay, so Stefan Biens concluded. Implant placement with GBR and concomitant subepithelial connective tissue grafting appears to be an appropriate procedure to correct buccal alveolar volume deficiencies and leads to stable results up to 5 years. Remember, so far, no such studies have been published. That what we do in a frequent clinical procedure, namely augmenting soft tissue volume, would be stable over time, facial to implants that we have placed. We said, well, with Goran Benic, let's look at the volume changes in patients that had dehiscence fenestration, where we augmented with standard procedures, and compare it to patients with intact bony envelope. So we have augmentations, hard tissue plus soft tissue, and we have augmentations, only soft tissue, where we had enough hard tissue. Here you see it, preoperative implant placement in GBR, 3 months re-entry, final reconstructions, 1-year follow-up and 3-year follow-up. Comparing these two groups. Again, the scans were done, the superimposition was performed, and here you see the results. So increase in buccal contour, preoperative to 6 months, almost 2 millimeters. Further apically, again, 2 millimeters. This was preoperative to 6 months. When we go to preoperative to 3 years, we see 1.8, we see 1.7. So we can claim stability over this time, and this is what Goran concluded. The augmented alveolar ridge exhibited stable buccal contours over the 3-year period. We have been performing these volume augmentations on a routine basis prior to placing Pontics for fixed bridges. We did it to improve tensibility and to improve aesthetics, form and function. But again, nobody had really evaluated over time what the outcome is. And I understand, because before we had digital scans and softwares to compare different time points, this was very tedious to do. The measurements were very difficult to do. So here we have a 10-year study. What you see is a soft tissue grafting prior to the start of the reconstructive phase. Traditional drilling preparation of abutment teeth for a 3-unit bridge in an area where we have a missing tooth and the patient did not want implant therapy. So we would raise a flap, place a soft connective tissue graft, let it heal. See, following healing of the graft, and then during the phase of temporization, we change the temporary and form an emergence profile, which at the end looks like a natural tooth, as if there was a root below. And in addition, we have good embrasures, good closures with artificial papilla there that help the patient to maintain it clean. Of course, this is only valuable if after 10 years it still helps the patient. So this is what we evaluated. So we had a 10-year follow-up. This is just one case. So again, the scans were done, the CAT scans were superimposed. And here we see the results. We looked at the mean distance between the two surfaces within the region of interest, which was where we had the pontic. There was a test group with grafting, and we said we need a control group where there was enough tissues to start out with no grafting. Again, to see if our therapy does mimic nature and help us provide good outcomes for our patients. Oops, excuse me, I was too fast for one. So here we see the mean distance, 0.6 millimeters and 0.2 millimeters. So very similar over 10 years. If we look at the change in height, right at the pontic from here to here, we have a change of 0.3 millimeters and 0.2 over 10 years. Again, we can claim stability. And if you look at the horizontal change in this direction here, then it's 0.6 and 0.2 millimeters. So, conclusions. After an observation period of 10 years, pontic sites grafted with subepithelial connective tissue grafts showed a high dimensional stability, demonstrating that soft tissue volume augmentations remain stable. So we're talking about a clinical procedure which is routine in many of our reconstructed patients, be it on implants or be it on natural teeth. Hansen and Khoury, sure you have heard of Fouad Khoury. He's an excellent clinician doing very daring augmentation procedures. He has developed his own techniques and he has really changed some of the aspects. And they've also looked at the volume when they do soft tissue grafting. They had 46 patients with 52 single implant caps in the maxilla, a volume deficiency 3 millimeters on the buccal side, so significant volume deficiencies, implant placement with at least 2 millimeters of buccal bone present, and then simultaneous grafting with a subepithelial connective tissue graft. So this would correspond in the material I've shown you from our department, the study of Goran Benic, where we did have enough bone volume. So they're really testing the value of the subepithelial connective tissue graft. It's a large number of patients, and they have a very decent follow-up with quite meticulous analysis. This is why I'm showing you this study. I think it's a very valuable one. So implant placement, then the subepithelial connective tissue graft, and the abutment connection. Here they do the analysis. They go on, insertion of the final reconstruction, follow-up 1 year, and a follow-up of 5 years. And they assessed the labial soft tissue thickness. Again, they used certain measurement standardizations to really have something that they were sure was valid information. They had a lower reference point. They kept their volume for baseline to 1 year after prosthetic incorporation. And they had one which was closer to the margin. The upper reference point showed a significant decrease in volume from baseline to 1 year. Remember, this is a time when we see the changes. It's also a reason why in our timing schemes, in aesthetically critical situation, we will put a temporary for 6 months or even up to 1 year. This is not a problem for the patients because it's a fixed temporary, it's usually screw retained, and it's for them very comfortable. It's maybe not the perfect aesthetics yet, but it's something they can very well function with. So they see the same thing. They see a decrease at the margin over the first year. None of the reference points showed a statistically significant change in volume in the period from 1 year to 5 years after prosthetic incorporation. So from both these groups, we have data showing that our volume augmentations, once the initial healing phase of 1 year is over, they will remain stable over time. So Hansen and Khoury conclude, implant placement with concomitant free connective tissue grafting appears to be a suitable procedure to correct buccal alveolar volume deficiency at implant sites and render stable volume over a period of 5 years. So this brings me to the final conclusions. First, data from preclinical and clinical studies demonstrate encouraging results with the use of collagen matrices for enlargement of keratinized tissue and for soft tissue volume gain. I'm happy to be able to quote studies from different centers, from reconstructive dentistry, from periodontology, pointing in the same direction. In a single center RCT, randomized controlled clinical trial, the 3D collagen matrix showed soft tissue volume augmentation similar to those achieved with autogenous soft tissue graft. It's only a single center, it's one university. We're now doing a larger study, and only then I think the data will be really reliable for you to make a decision whether you want to use it yourselves as well. But we think that the autogenous soft tissue graft can be replaced by collagenous graft substitutes. As I said before, we've tested many materials. Most materials, some are even biologically active, they lack the gain of volume. They're good for surface alterations, but they're not good for the volume gain. Significant improvements of patient well-being can be expected when using collagen matrices and avoiding harvests of autogenous soft tissue grafts. Most of the times, of course, there is always morbidity associated with the donor site. Most of the time, things heal well. But sometimes you even have some necrosis there, and the patient will be in pain for extended periods of time, and the healing will even take weeks. And finally, the short-term results of tissue augmentation regarding implant survival and buccal tissue volume are also stable long-term. This brings me to the end. Again, I would like to thank the team in Zurich for doing all this excellent work. And I get the chance to travel to India, spend time with you and speak with you. This is a great privilege for me as a chairman. And I thank all of them for their great enthusiasm to do dentistry. And you, thank you very much for your kind attention.
Thank you, Dr. HAMMERLE, for an excellent presentation on soft tissue management.